Good evening. Thank you for having us tonight. This is my second time presenting at the Summer Healthy Living Lecture Series. The first time, I think, was right after the Affordable Care Act came out, and I think we were talking about understanding your health care bill and health care costs, and there was probably 150 people, standing room only, in here. This is a little more comfortable. So thank you for coming out tonight at the end of the summer series. This is one of the things I love about Fairbanks. I was a little nervous coming here, and I look around the room, and I probably know half of you personally, which makes this a little more comfortable. We'll have some fun this evening. Tonight's topic, as you can see, and I was told that we win second place for longest title of a presentation. I'm not sure how this was created, but we really have two topics for you. I'm going to sort of set the stage, and Linda covered some of it in her intro, but talk about some of the events in our community that led to our current healthcare structure, but really focus on some of the historical significance of what it means to be a community hospital and why in a community like Fairbanks this is important, even as healthcare evolves in today's very modern, fast-moving world. But then I think the most significant part of tonight's presentation, or the most interesting for the audience, will be Dr. Swenson's discussion about our partnership with Mayo Clinic, and how we're using that in Fairbanks to better care for the community. And then we'll, of course, have plenty of time at the end for questions. So we'll click along and begin our discussion today. We've already done introductions, excuse me. I wanted to start with this, and a few people in this room I recognize as having recently attended the annual meeting of the Hospital Foundation, and so I am borrowing a few themes that I used in that meeting. But I think this is significant for all of us as residents of interior Alaska. Each generation goes further than the last because it stands on the shoulders of that prior generation. And for me, I'm here today because I get to stand on the shoulders of people like Mike Powers. My dad happens to be here in the front row. I think of current leaders like Jeff Cook and Joe Fallhaber, who lead the Hospital Foundation, Mike Kelly, who's no longer with us, and many others. So it's a privilege to be here and be a part of the leadership of this organization. And this is very relative, I think, to our past as a community. So how many people were living here August 15th, 1967? So a fair number here today. I was obviously very young. I'll be 52 on Friday, so that makes me too young to remember. And my family moved here in January of '69. But this is a monumental event that shaped our community. And it certainly shaped the future of healthcare. Because for those of you that were here, and you'll remember the history, we won't walk through all of this, but there was already challenges for the old St. Joe's Hospital and the Sisters of Providence, and the likelihood that they wouldn't be reinvesting in the community at that time. But I think the flood sort of sealed the fate of the old hospital, and the community was left without a solution. And as I recall the story, there were at least two, possibly three attempts to issue bonds to fund a government-owned hospital. All of those efforts were unsuccessful. The result was community leaders coming together and forming the Greater Fairbanks Community Hospital Foundation in 1968. The foundation continues to be the ownership body today. This is an open community, not-for-profit organization that has been the ownership body for now 50 years for Fairbanks Memorial Hospital, and then the subsequent parts of our health system that have been added to that. So we look at that list of names on the right-hand side: William Wood, C.W. Snedden, Harry Porter, Steve Stevens, Con Frank, and Ron Nerland. This is a generation that is passing, but they are the builders of what we have as a community, and we owe them, we owe them a great gratitude of debt. It is on their shoulders which we stand today. So as we dive into the material, I just wanted to refresh for those who aren't familiar. We're throwing around some new terms and some new names lately. So this term, Foundation Health Partners, is now the name of our operating company, and I'll cover that in a little more detail. But when we refer to that, that's sort of now the mother organization, if you will, for Fairbanks Memorial Hospital, the Denali Center, Tanana Valley Clinic, and all the subcomponents of those operations. And so we consider ourselves one healthcare system for the community as Foundation Health Partners. One of the reasons this background is important, and I think the topic is important, in fact, because healthcare is one of the cornerstones of a healthy society. And when you take the concept of society and you boil it down to a remote community at the end of the road in Fairbanks, Alaska, it's a critical part of the success of a community. We look today at our neighboring community of Delta Junction, who's desiring to have a hospital, may not have the numbers to sustain it, but the concept is very logical. Without a hospital to ground a healthcare system, it's hard to create the viable and long-lasting community that we all desire to live in. The community hospital term specifically does have some meaning and some historical significance. So community hospitals historically play a very important role, not only in small rural farming communities in the upper Midwest, which is sort of the classic model that we picture middle-sized communities like Fairbanks serving approximately 100,000 people. Community hospitals can also exist in larger population centers if they meet certain definitions. There are about 1,900 rural community hospitals, according to the American Hospital Association, in the U.S. that serve approximately 51 million Americans. So this is, again, a significant portion of the healthcare infrastructure of our country. Did a little bit of research on this topic, and there's not unilateral certainty from the academic sources, but these 4 criteria sort of sit at the heart of the definition of what does it mean to be a community hospital. So what I decided to do was just talk a bit about what we have in Fairbanks, our opportunities and challenges as it relates to these 4 characteristics. So the location is the easy one, right? So we are a long way from the next level of service. We are a long way from backup should anything happen. So clearly, by the concept of location, we meet the definition of a community hospital. According to Medicare, which governs a lot of the rules for healthcare and a lot of the definitions, I think the classic definition is very small, actually as little as 35 miles from the next adjacent hospital to meet this definition. We obviously cover that by tenfold. This next definition is very important, and this is a mission, an element of mission held in common across most hospitals in the United States, certainly most all of the not-for-profit organizations, and that is the role of caring for the underserved within our community. As I thought about this, there's the obvious definitions of underserved, right? There's poverty would be the number one thing that comes to mind, right? So socioeconomic status, if you have no money, it can be hard to access a doctor or other healthcare services. In today's modern healthcare economy, it can be equally challenging. Even if you have some means, you may not be in poverty, but if you do not have insurance or you do not have adequate insurance, you can be equally deemed as underserved. You can have challenges accessing the healthcare system. And then I thought even further to go back to location, even our remoteness here in a place like Fairbanks or in Delta or in Tok or in Nenana can also be factors in underserved. If a person doesn't have mobility, if a person doesn't have the ability to travel, they now, to me, meet this definition, and we have to take special care that we design systems to serve them as well. So my last phrase there, take special care to design, is on purpose, because that's what I want to talk about here is what does it mean to be a community hospital, and look at some of the access challenges that we're trying to address. So one of the definitions is very obvious. As a hospital, as a quasi-public facility, we have certain obligations to 24-hour-a-day, 7-day-a-week service throughout the year. Clearly, that's not all services. Many healthcare services are still in an office environment in a Monday through Friday capacity. But the classic hospital picture of an emergency room of nurses and doctors and other professionals providing care all night, all weekend, is what we do. It's not just the emergency room, because behind the emergency room lies radiology and lab and pharmacy and housekeeping and security and maintenance. Even in the middle of the night, all of those people are working within our facility. This creates great challenges. We have the challenge of staffing, what I think be the greatest one, and most people are aware of that. We live in an amazing place, but it's not always easy to find specific forms of talent. The specialists we need, whether they be physicians, nurses, pharmacists, techs, or others, are very hard to come by, and recruiting and retaining them is a challenge for us. We're constantly challenged by the resources required, largely the people hours required, to work to maintain the highest level, the highest standards of quality that we're providing in our service to the community. Constantly changing regulations is another challenge. I jokingly referenced the Affordable Care Act earlier. Regardless of whether people think that is a good piece of legislation or bad, it's kind of irrelevant. But that was, there will be experts in the room, but that bill, the actual bill itself, exceeded 1,000 pages. And out of that, I don't know the exact number, but at the time it was estimated that it would produce something like 20,000 pages of regulation out of that 1,000-page bill. So just to give you a glimpse of what we deal with in healthcare with regulation. We have to have the capacity to meet surges in demand. The emergency room is the classic example, but labor and delivery is another one. You don't know when those babies are coming. And so we have to have a staffing model that allows us to flex up to care for whoever comes in the door. And somehow we have to achieve this with some sense of financial stability over the long term. Which brings us to talking about some of our current needs in Fairbanks. This term access, you'll hear us use this a lot. Mike Powers taught it to me many years ago. It's one of the foundational principles that we live by, is creating access for care. This happens in a clinic environment, happens in a hospital environment. This list is a list of medical specialties that we are currently recruiting for or contemplating building into our system. They are needs that are currently underserved or not met within our structure. Later on, if we have questions, Dr. Swenson or others in the audience may comment on specifics. But we're short on adult family medicine providers. Behavioral health is truly a crisis across Alaska, and we could go on down the list, all shortages, and notably these are all physician shortages that will be required to drive these services forward. One of the areas where we've had success, and another element of access that I wanted to touch on, goes back to that type of insurance that I mentioned earlier. Many people in this room are probably aware that it can be challenging to find a physician resource if Medicare is your insurance. That is not because doctors are cruel and unkind. That is because in places like Alaska, where our cost structure is high, all of the other payer types virtually pay better than Medicare pays on a rate perspective. So a physician office cannot see unlimited volumes of Medicare patients because they actually lose money on each transaction as a business person running their practice. So when this crisis started to emerge in Fairbanks back in the mid-2000s, 2006, 7, 8, there was a crisis point in Anchorage where you physically could not get a new appointment. At that time, the physician owners of Tanana Valley Clinic met with the hospital foundation, agreed to merge together, and the docs sold their practice to the hospital foundation, became part of this community health system. Since that time, the physicians at TVC have been committed to growing Medicare access, and these numbers show you what they've accomplished in growing the number of appointments from about 10,000 a year to almost 25,000 appointments a year for Medicare-covered individuals. So that's a source of pride for us in coming together to help meet a community need. This challenge, though, will continue going forward. Other challenges include some of the, what I'll refer to, I guess, as the social elements of medicine. These are challenges that all communities face, and certainly we face them in Fairbanks. From a healthcare delivery system and a community system, they're extra challenging. There's not one button to push, there's not one single solution. These are challenges that require different agencies, different people coming together to form community solutions. So we talk about alcohol and drugs, we talk about behavioral health crisis. We've had successes in there. The Sobering Center is a recent small success. Multiple agencies partnered together. Tanana Chiefs Conference took the leading role. Foundation Health Partners, the City of Fairbanks, the State of Alaska, and I'm going to, Fairbanks Native Association, I'm at risk of forgetting someone, I apologize. But to open Sobering Center this winter which is making a difference. It's giving those individuals a place to go besides jail or the emergency room, and it's working. A number of other examples here, which we can get into with questions at the end if we have time. Over on the right side, though, are some of the challenges. How do we make this sustainable? Society does not generally pay for these services through insurance such as Medicare or Medicaid or through other public dollars. Society doesn't pay or doesn't pay well. So we are going to have to rally together as a community to work on solutions to these crises. The economic impact. On the earlier side, that was one of the 4 criteria, right? Location, access to care, economic impact, and governance. The definition of community hospitals, most, if you look, are a significant economic anchor in their community, and we are certainly such here in the interior. Foundation Health Partners now employs just over 1,700 people. We have an annual payroll that now exceeds $100 million. And what's really great is that's the part of the payroll that is local people living and residing here. We do spend another $6 million a year on out-of-state labor to fill gaps in our workforce, temporary, what we call locum physicians, pharmacists, nurses, etc. But this $100 million payroll then multiplies as it's spent within our community. These people own homes. These people are us in this room, of course. Own homes. Their kids go to our schools. They're spending money at local businesses. The healthcare operation has a major economic impact and it provides jobs within the community. That said, it's not tonight's topic, but we can't ignore the opposite side, which is the cost of healthcare in Alaska is high and represents a related economic challenge that we all have to deal with over time as well. The last part of the 4-pronged definition is governance. So I wanted to touch on this for a few minutes because this is significant here. So as I did the reading, independence used to be a core part of the definition for community hospitals. As healthcare has changed, that's not necessarily true. You can see good community hospitals who are part of larger health systems in a partnership or owned model. And certainly, we have been locally owned but managed by an outside healthcare company, Banner Health, and before that Lutheran Health, for 45 years, quite successfully. However, this last phrase, most experts agree it needs to be governed locally by people in the community. And so while that has always been true, there's always been an advisory board of the foundation as part of governance. Going back in 2016, the foundation declared their independence from Banner, and Banner and the Greater Fairbanks Community Foundation agreed to part ways. The short version is, and it's related to that definition, the Banner's vision for success in a changing healthcare world was a very corporate-centric model. Their plan was wise for them as a healthcare delivery system. They had smart plans. Those plans, however, did not have enough flex in them to accommodate the needs of a remote community in Alaska, where we do need more local input on where we need to focus, where we need to invest, what are the services to bring to the table. So after 45 years, we parted ways. While there was tension initially and a lot of stress, Banner actually was a cooperative partner in helping manage that transition. As Linda said, it was incredibly difficult, without question. We are all older and fatter and grayer due to the experience. But we stand here today pretty proud of what we've accomplished. Again, 1,700 employees. We've got over 200 active physicians on medical staff. 88 of those physicians are within those employment numbers, which is, for those who aren't aware, is a pretty dominant trend within healthcare across the country as younger physicians generally seek to be in employed models. But this local governance thing is very significant. I started out talking about standing on the shoulders of others. This is a picture from a few years back on the right, because Harry Porter was still with us in this picture. But this graphic on the right gives you the organizational chart, if you will. The Greater Fairbanks Community Hospital Foundation remains the not-for-profit ownership group for all of our resources as a community health system. What they did was they really just replaced Banner with now a wholly owned subsidiary that is the operating company, and that is Foundation Health. So in retrospect, we've joked, we may have used the word foundation too many times in this naming convention, but it's a good name and we're going to stick with it. So nothing has changed in the ownership structure since 1968 and 1972 when we opened. The same not-for-profit community foundation as the ownership group. They now own their own operating company, which operates the clinic, the hospital, and the nursing home. These are the list of Greater Fairbanks Community Foundation executive committee members, trustees, and the board members of the Foundation Health Partners, which has its own governance board. So many of you know these people. These are the community leaders who are at the table with all volunteer time helping us guide this organization forward. I also thought it was relevant to touch on the timeline of where we've been. When the hospital was built in 1972, Alaska was booming, right? Growth times were upon us. So there was a lot of growth in population, a lot of growth in economy during the 70s. There was therefore a lot of growth in the demand for healthcare. Technology was emerging, so you can see the building timeline that went forward. And then some of the events were really monumental. In 1994, Denali Center, the old Carriage North, Jeff Cook led that fundraiser to raise money to bring the hospital or to bring Denali Center over to the hospital campus. Changed the world. Denali Center is an amazing 4- and 5-star facility for long-term care, amongst the best in the state and the best in the country, where it's a flagship of what we have to offer. Cancer Treatment Center in 2000, the Heart Center in 2010, which has since been named after Harry and Sally Porter. So just an amazing progress, and our most recent piece of advancement is replacing a very old building with a brand new facility for surgery, which opened in the spring of 2017. So one of the things that we've found an advantage is in leaving Banner and being independent, it's opened up a world of possibilities for new partnerships or expanding of old partnerships unfettered from past restrictions. So we've long had several of these partnerships on the list. The bottom two are new. But we have physicians on our team through the Tanana Valley Clinic and the Porter Heart Center, but we also partner with numerous independent physicians in the community. Healthcare, by definition, requires partnerships. You really can't do things alone in today's world. It's all about interdisciplinary care and partnerships. We have tremendous historic partnerships with Indian Health through the Tanana Chiefs organization. We have tremendous historic partnerships with the military through Wainwright and Eielson, specifically the command crew at Bassett Army Hospital. The military physicians are cross-credentialed. They come to our medical staff meetings. They follow their patients in our hospital. Two new endeavors since going independent are we have partnership with Providence to provide telestroke services in our emergency room. Great advancement in care, great example of how we can use telemedicine going forward. And then I'm going to turn over here to Dr. Swenson in a moment to talk about our newest partnership with the Mayo Clinic Care Network and how that fits into our matrix of what we're doing with the community. Dr. Swenson, I'm afraid to click ahead because I fear we might be entering your part of the presentation. So why don't you come up here?
Okay, sounds good. Thank you, Jim.
And I'll join you back at the end for some questions here.
So I guess what I wanted to start with was really kind of go back to the first slide where we had up here the vision and mission of Foundation Health Partners. And you recall a couple of lines in there. One is a lifetime of excellent care. The other is excellent care every time. What I really want to focus on is that term excellent. What does that mean? What it refers to really is about quality in care. What kind of quality? How do we come up with an idea of quality for care? And that's really been a difficult thing to get our hands around and to understand is what does it mean to have good quality health care? This is a picture of Dr. Doolittle, who was really one of the founders, I think, of healthcare here in Fairbanks. And here's this phrase about a lifetime of excellent care. provided by your community healthcare team, which is really the vision statement of Foundation Health Partners. From the cradle to the grave was a statement of Dr. Doolittle's. I think maybe making that a little more operational to what we have right now. It's really from the nursery to hospice. We provide those services all through the lifetime of care, which I think is really important. But really, what I wanted to talk about is excellence in care. How do we define that? What does that mean? And I'd love to have this as an open conversation and asking folks about what quality healthcare means to you, and maybe during the questions we can talk about some of that. But let me turn to the Institute of Medicine, because while this is a rather wordy definition, I think it really encapsulates and really captures a lot of what we try to get to with healthcare quality. So according to the Institute of Medicine, healthcare quality is the extent to which healthcare services provided to individuals and patient populations improve desired health outcomes. The care should be based on the strongest clinical evidence and provided in a technically and culturally competent manner with good communication and shared decision making. A lot of words, a lot of things to think about. But I think what that boils down to is that really what excellent care is, what quality care is doing the right thing and doing it in the right way. And to me, that's really what quality care is. Another way to try to capture that is to ask the question, is this the kind of care that you would want your family member to get? And really what we as a community hospital are focused on is really that question, doing the right thing in the right way. And is this how I would want my family member, because that's where my family would go to if they needed health care, is that's how I would want them treated. First of all, when we talk about quality, there's various kinds of regulations. Jim kind of touched on the regulations and really the burden of regulatory measures that are out there right now. Something that really drives quality in the country is CMS, or Centers for Medicare and Medicaid. That's a federal organization. That's the group that really funds everyone who's on Medicare and Medicaid, obviously. And they set lots of standards and regulations for how hospitals and healthcare are to be run and to be delivered. Joint Commission is a group many of you may have heard of. That's a group that comes to the hospital, goes through the hospital and many hospitals in the country really with a fine-tooth comb. Gives Jim headaches, I'm sure, whenever he hears that they're coming, but it really provides a good service because it's an outside service that comes in and looks very closely at what's happening at the hospital and looks at lots of defined quality metrics to make sure that safety is being protected for patients and that quality care is being provided. So we have these regulatory things which I think are really driven by quality. And also importantly, these are publicly reported measures. So not only are these things regulations that we have to comply with in order to be accredited, they impact the way that we're paid, but the results are now publicly reported. So any of you can now go on internet sites on the web and look to see how our hospital is rated by Joint Commission. You can look to see pretty soon how individual physicians are rated. So these publicly reportable measures are really going to be very impactful and important in terms of how we do things at the hospital. But I think when it comes down to it for a community hospital, what's really more important is what does it look like to care for your family? What does that really mean? And I have this slide up here of Laura Brunner and one of her patients, just to remind me to thank her for putting together a lot of these ideas. She has now become one of the quality gurus at the hospital, and she's done some great work in trying to articulate really what quality means at the hospital and at the clinic. So first of all, it means staying current. How do you stay on top of doing the right thing? How do you maintain being up to date with current developments in healthcare? But also avoid jumping on every bandwagon. We all hear about things that are published that say, well, this is the latest, greatest research, and then 6 months later, something else comes out that seems to reverse it. And it can be really confusing sometimes, and how do you sort of set your path and finding things that really make sense? So some of the systems that we have to try to help deliver quality health care that can be put in place are things like guidelines, guidelines that sort of define how care in a certain circumstance should be provided. Order sets that help to sort of articulate and put together a set of elements of care that are provided to patients, usually in the hospital. Nursing policies to make sure that nurses are providing care in the same way. Providing uniform care like that doesn't guarantee quality, but at least it makes it much easier so that if changes have to be made and there's some problems with quality, we can make those changes much more easily if everyone's already doing it the same way. Multidisciplinary teams, patient education, these are all really important, critical aspects of this. I think, though, the challenge that really faces a community hospital like ours is where do we find the expertise and clinical resources to ensure excellent care every time? When we had Banner, we had a deep bench. We had a lot of expertise that we could turn to say, what should we do in this circumstance? How do we manage this kind of situation that we may not have managed before? Now that we're independent, that becomes much more of a challenge. And where do we go for that? We're not big enough to have a large group of specialists that we can keep in our back pocket and keep here in Fairbanks. So we have to be judicious in how we use that. But then where do we reach out? Where do we find this level of expertise? And what we found is this great collaborative relationship with Mayo Clinic. This has been an opportunity that really has presented us a way of helping to get those clinical resources from the best experts in the country to really help strengthen our processes here. And we just so happen to have some of the folks from Mayo Clinic with us tonight. We're celebrating our first year anniversary with Mayo Clinic. And so I just want to introduce briefly some of the folks who are here. Dr. Mark Larson, who is associate medical director with Mayo Clinic and a GI physician himself. We've got Ryan Kelly, who's been up here, 6 times or so now, Ryan, up here to Fairbanks? Four times, okay. But he's really become the face of Mayo Clinic and helping us to sort of figure out how we go about this. Colleen Bjerke, who's here, she's been a huge help, and she and I email back and forth a lot about these different projects of things that are happening. And Linda Maddie, also here, I think probably for the first time here in Fairbanks, also one of the operations administrators. So thank you all very much for being here tonight to help us with this and help us understand this. So what does Mayo Clinic Care Network, what does it do? They're really about collaborating with local hospitals and local healthcare networks. They're about building a program or supporting a program with a network of like-minded organizations. And so what this network now consists of is at least 45 organizations. Is it more now that are part of this? About 45? That are throughout the nation and actually in different, several international venues as well, that really partner together and can work together to share the resources from Mayo Clinic, but also share resources with one another. So we can learn from one another who may be in similar kinds of circumstances, similar sized communities. They're really about improving the delivery of healthcare in the communities. And it's by giving us access to Mayo Clinic and all the medical expertise that they have there both in terms of their physicians and their specialists, but also in terms of how they do things, how they run a clinic, how they operate. They've been doing that so well for so long. So a lot of collaboration is happening throughout the country and the world, really. So this relationship with Mayo Clinic, it might be helpful to sort of put this together to contrast what it is and what it's not. So what this is collaborative, as I mentioned. It's not about governing. They're not here to govern us. They're not here to tell us what to do. They're here to provide resources, so when we need help, they're there to help us with that. They're very much about being quality focused, but they don't monitor us. They don't look at our quality metrics. They don't look at the things that we pull out to look at how we're doing in terms of quality care unless we ask them to. So they're not here to monitor us or look over our shoulders. They help patients to stay home. And that's a big part of their mission and really helps us a lot, because by giving us access to the expertise remotely, we can oftentimes keep people here. And I have some more specifics about that in just a little bit. They're about complementing our local resources and helping us out here, not about ownership, not about exclusivity. Being partners with Mayo Clinic doesn't mean that we can only go to Mayo Clinic for that expertise. We can still go to Swedish, we can still go to University of Washington, we can still go to Providence in Anchorage, or send patients there to get that advice that we need it. But it provides a great resource for that. It's really what it is, it's about giving us the opportunity to pull information, to pull resources from the best that there is in the country. It's not about them trying to push these things on us and tell us what to do. So I think that's a really important difference that we really appreciate as the local operators here in Fairbanks. So let me talk about some of the specific examples of things that we can do or that we can get through this Mayo Clinic Connect that really helps provide this great resource. The thing that has made my life much easier as a physician is really this e-consult service. This is a great service where if I have a patient that comes into my office with a fairly complicated problem that I don't necessarily have all the answers for, I can send documentation from my medical record to a specialist at Mayo Clinic to get their advice. And it comes back as a written recommendation that then can go on the patient's record. So that's a very useful piece of information to have. It's something that we as Foundation Health Partners pay for, but it doesn't cost the patients anything additional. So it's a great service to patients to have this particular resource. Let me give you an example just to help you understand how this process works. So say, for example, that Jim comes into my clinic. Now, he's not really my patient, so I can make anything up here. There's no violation of confidentiality here. But he comes into my clinic and says, gosh, I've been having this gut ache. It's just been bothering me so much the last few months or so. I can't figure out what's going on, but I have to do something. And I start asking him questions about this. He says, well, it seems to get worse when I eat. Definitely seems to get worse during the weeks before an FHP board meeting. I'm like, oh, okay, I think I know what's going on here. So Jim, what have you done about this? Well, I've tried some antacids and tried some over-the-counter medicines, but it just isn't taking care of this. So I say, well, Jim, I think I know what's happening, and examine him, get some labs. But I think what we really need to do probably is take a look in your stomach and see what's going on. You're of an age group now, 52, we just heard, where the risk of having bad things happen in stomachs is a little higher. So I take him into the endoscopy suite, take a look down in his stomach, and lo and behold, he's got this strange looking thing on his mucosa of his stomach that just doesn't look normal. I mean, I don't know what it is, but it doesn't look normal. So I take a bunch of photographs, take a bunch of biopsies, package all that stuff together, send it off to Mayo Clinic. Probably Dr. Larson, as a GI specialist, may get it from that end. He takes a look at all the data, my notes, my pictures, takes the actual slides from pathology, takes them down to his pathologist at Mayo Clinic, looks at them again, looks through it, and then sends me back written recommendations about what his impression is of what's going on here. That can range anywhere from, gee, I'm not quite sure what this is either. It's not really clear. You probably should go back down and get some more biopsies and send them back in, and maybe we'll get a better answer that way. Or it may be, oh, gee, this isn't looking good. He really needs to see a specialist somewhere, probably to have surgery. We can arrange this through Mayo Clinic. That's what the referral's about. And if Jim chooses to go to Mayo Clinic, his records are already there. So he can just go down there. He's already a patient at Mayo Clinic. If he decides to go somewhere else, University of Washington, Swedish, that can happen too. Or it may just be that the note comes back and says, no, this is nothing. Don't worry about it. It looks funny, but it's nothing serious. And just reinforces Mayo's right all along. It had to do with the FHP governance and those meetings. And so this is just a stress-related kind of thing. So this is really a great service that we can get through Mayo Clinic. Over the past year, we've had a chance to do 200 e-consults. And that's a large number of us reaching out to Mayo Clinic to get advice that really has helped our patients a lot. These are the areas, the specialists that we've talked to at Mayo, or that we've communicated with at Mayo Clinic to get their advice. Have to be proud of my department, internal medicine at TVC. Of those 200, we've done over 100 of them. And the champion of all of those is actually Mike Strum, who's here tonight with us, Dr. Strum. He's done over 55 e-consults himself over the past year. And so, Mike, thanks for coming tonight. I wanted to give you the chance to maybe say a word or two about what this has meant to you as a practicing provider, and how important this service is.
Sure. So, well, thanks, Mike. I think this is a really important service, the e-consults. Oh. So I think the e-consults are really important because, specifically here in Fairbanks, because what I'm asked to do as an internal medicine doctor here is different than what internal medicine doctors are asked to do in a lot of places. In California where I trained, we had every specialty that you can think of. We had them. So if you came into my office and you had inflammatory bowel disease, that's a GI referral. I don't need to think very hard about that. But here in Fairbanks, I'm the GI referral. And so that's a lot harder. And that's not something that I was trained in depth to do. I saw it, I spent some time with them, but I don't have the fellowship training, which is an extra couple of years of training in that. And so here in internal medicine, it's not just GI, it's rheumatology, it's pulmonology, it's pain management, psychiatry, geriatrics. All of those things are referred to us, and we love doing it, but what the e-consults allow me to do is I can see the patient, go through all their records, formulate an impression, and I usually have an idea of, okay, well, this is what I think we need to do, but then I can type that up and send it to Mayo and what I say to the patient is, well, I'm going to type it up and I'll send it to the big brains at Mayo and make sure that they agree with what I think we should do. And so I can draw on their experience and their fellowship training for that patient in front of me. And it really enables me to provide a lot better care for a big population of patients who need that specialty care that we just don't have. And so I think it really expands the patient group that I'm able to take care of. It's something that I'm really passionate about and I really like using.
Thanks, Mike. Appreciate that. We did a study. When was that, Carol? Back in January that we did a study. So this was after we'd only done about 100 e-consults by that point, asking providers about what impact these e-consults have for our docs. And you can see from the chart here how positively this has been received by our providers, how much impact it's had on patient care. 68% said this has been a very positive experience. It gives us just a really good resource for stuff that has made a big impact. So 93% of the providers that we surveyed thought that this had a positive impact on care. So it's really been a great service. Asking the question, how many of your patients would have or might have gone outside to seek care had we not had the e-consult service? You can see here 37% definitely would have had to travel if we didn't have this e-consult service. So we're really, I mean, this is not just lip service to saying we're really keeping patients here locally by having Mayo Clinic as a resource that we can refer to and get their expertise from that. So it's been a great, really great service. Some other things that really help with provider access to Mayo resources and help with our own education. There's another service called Ask Mayo Expert, which is something that is there all the time, and it's integrated into our electronic medical record. We can access that and ask clinical questions, and that then gets us access, sort of like with Google, to anything on Mayo guidelines. So it really provides a good resource, a good set of information that we can refer to try to get more information about specific things. There are opportunities for continuing education. CME is continuing medical education. There's grand rounds, webinars that are available through Mayo Clinic. E-boards, there's a cancer tumor board. There's an inflammatory bowel disease board. Mike was talking about inflammatory bowel disease and how much of a challenge that is, I think, for us to deal with here. So there's an e-board that meets weekly, actually, to talk about difficult cases at Mayo Clinic that we have access to. Unfortunately, that happens at 8 o'clock at Minnesota time, which is 5 in the morning here in Alaska. So not many of us probably take advantage of that particular one, but it's nice to know it's there. And they're also recorded, so we can always go back and watch the recorded ones. There are collaboratives that help us work with other members of this network to try to work on issues that impact quality, research projects that we have in common, and also areas of professional development that we can work on. So professional leadership, focus groups, and other kinds of networks that we can work on. Here's an example of in the Ask Mayo Expert. This is one that I use quite a bit in terms of anticoagulation management. So when I take patients to endoscopy, for example, and they're on some kind of anticoagulant, just as a reminder of how long they have to stop those medicines before I can take them to endoscopy suite. This is a great place where I can go and just get reminders of that. It has ways for me to it has information about the medications themselves, has information about calculating dose adjustments that might be available, and has patient education materials. So it really has some good information. So for any particular problem that may have, it's another great resource that we can use. Another nice thing circled on the bottom there is I know how current that information is contained in that particular website. So this particular one was reviewed in January of this year, so I know it's really very current, very up to date. Another really great resource that we have through Mayo Clinic is what's called healthcare consulting. And this really kind of moves away from individual patients and really is about getting help in developing programs, developing new ways of doing things, developing operational systems at the hospital that help to drive quality of care. What any of us can do is to basically submit questions to Mayo Clinic and ask, how do you do things at Mayo Clinic? What advice can you give us about these policies? That information that may come back as policies or procedures that they use at Mayo Clinic that we can then share and use here locally. It may be about protocols, guidelines, summaries of information that are relatively easy for them to pull out of their database and send to us. It may be about conversations that we have with content matter experts there at Mayo Clinic. So if we're thinking about some new program that we want to try to develop, how best can we use that? We're trying to recruit a urologist here to Fairbanks to work at TVC. How to set up a urology clinic is something we don't have a lot of experience with at TVC. And so being able to talk to folks at Mayo Clinic who know those kinds of things, how do you set up a urology clinic so it's successful? That's been a very helpful thing. On-campus consultations, we can ask that people from Mayo Clinic come to us here if we have a large group of physicians. There's a great session we had last winter about physician leadership. Had an expert from Mayo Clinic come and talk to us about about how to develop physician leaders. That was a really, really important and helpful time. And there's also opportunities for us to actually go to Mayo Clinic as well to get consultations on site there. So that's been a great resource as well. Here's some current examples of healthcare consulting. Endoscopy preceptors. So as those of us who are doing endoscopy are getting a little grayer in our beards, recognize that we have to be thinking about passing on this torch and passing on these skills to somebody else. How do we go about doing that? Most physicians who get these skills in a fellowship training program. But as Mike was saying, we don't have any GI specialists here in Fairbanks, and so we need to think about, well, how do we provide this service in a different way? And so right now we're working on trying to set up a way of sending our docs to Mayo Clinic to get some early training in this that we can then continue back here on site with some preceptoring. Equipment purchasing, CT scanner. We just recently made the decision to buy a new CT scanner at the hospital for over $3 million. That decision depended a lot on Mayo Clinic and helping us try to figure out what that would mean so we could take advantage of their resources for that. Physician recruitment, that's something that we're always working on, always struggling with. It's become Mike Powers' biggest thing since he's come over to TVC and trying to figure out which specialties to recruit, how to recruit them, how to put together packages that are attractive to physicians coming here. So talking to folks like Mayo Clinic and getting their expertise can really help us with that as well. We have some projects coming up this fall dealing with the opioid crisis and chronic pain. And really, we're planning a speaker event here in October that will help with that. I want to, kind of getting back to the quality issue, I want to sort of use one example here, maybe have a real live healthcare consulting happen right here. And that is one of my favorite procedures are colonoscopies. I'm sure for many of you, it's also your favorite procedure. And sort of looking around the crowd, I would guess probably most of you have had the opportunity of having had that done at some point in your lives. But really, how do you define quality in colonoscopy? How do you figure that out? For many of us, just, well, as long as we slept through the whole thing, it's fine. It was a good quality procedure. And say, well, okay, that's part of it. I mean, as long as we had the sedation done right, that's part of the quality in determining that this was a well-done procedure. But that's not the whole thing. So there are lots of things that are suggested across the country in terms of what makes a good quality colonoscopy. I'm going to turn to Dr. Larson here, a GI specialist, and ask him, Dr. Larson, what at Mayo Clinic, what do you use as quality metrics for colonoscopies?
Spontaneous consultation, yeah.
Here it is, right here, yeah. Yep.
Right. Let me answer that, but first let me just say it's a great pleasure for our team to be here, and we're celebrating the 1-year anniversary with Jim Lynch and his team. It has been a remarkable first year of this relationship. As Dr. Swenson and Jim Lynch mentioned, we have, I think, 46 sites now, including 7 international sites in the care network. And when the Fairbanks team joined last year, we were thrilled, in large part because of just the high quality of the organization and their willingness to partner on all the right levels. And the main theme we heard a year ago was partnering together to enhance the care of patients here in Fairbanks and interior Alaska. And what we've seen in the last 12 months has been really remarkable. My colleague, Colleen Bierke, Colleen, raise your hand again. Within a couple months, she had received 500 requests for process and practice improvements and exchanges, which Colleen has jumped at to be able to kind of provide in a timely fashion to help enhance care for patients here, enhance processes of the nursing team, the administrative team. So it's just been a robust relationship, and as Dr. Swenson mentioned, over 200 e-consults. That's just outstanding. I mean, this is probably the shining star in our system in terms of the level of engagement within this first year. So we're here to celebrate that, and the next day with Jim Lynch's team and others, we'll be talking about what's working well, what can we do better, what do we want to look for in the next 12 months. So our team hopes to go back tomorrow night with literally a list of projects we can work on together over the next 12 months, which will continue to enhance the care that patients receive here in Fairbanks. That's what our marching orders will be when we leave tomorrow night. But to get back to your question.
Please,
okay?
yeah.
So colonoscopy. And I'm thrilled about what's coming up. We've got a team. We have 76 GI docs where I work, all in one area. So it's a large team. And we have a couple that specialize strictly in endoscopy education. And they're going to be working with the Fairbanks team to kind of bring them up to speed to the highest level of being able to perform not only routine procedures like screening colonoscopy, but more of those higher level interventional activities. So if somebody has a bleeding episode in the middle of the night, has a piece of food caught in their esophagus, what do they need to do to provide the highest level of care right here using their Fairbanks resources and Fairbanks providers and physicians. So we look forward to that engagement. Again, back to the question. So colonoscopy should reach the end of the examination, we call it the CEPIM, where the colon starts and finishes. It should get a certain percentage of time the provider gets to that mark. If they're not, there's a struggle, and there's a reason for that, so we have to keep track of that really closely. They should be able to, point number 2, find pre-cancerous lesions at a predetermined stage level a certain percentage of the time. So for example, we have a ballpark mark we need to hit. Let's say it's 40% for men over 50 and 35% for women over 50, slight difference there. If they're not hitting that, there may be something wrong in their technique or their observational skills. They should withdraw the instrument in a certain length of time. If they're not, that's another quality metric we have to look at. What is their complication rate? That's a critical measure. What are their missed cancer rates, which is a very critical measure. So in my institution, we sit down in a very uncomfortable meeting once a year, and we go over all the complication rates, were there missed cancers, were there bleeding episodes, we need to know that. And if there are numbers beyond the unacceptable level, then corrective measures are put into place, and we can certainly talk about that. So there's a number of high-quality marks, which your team will be reviewing very shortly here. If they meet those marks, they're considered a quality endoscopist. If they don't, then there's things they have to keep working on. So we'll talk about that in the sessions ahead.
Great.
Thanks for the chance, Jeff.
Thanks, Dr. Larson. Yeah, that's great. So healthcare consulting in action. So great. And this is not rehearsed beforehand either. So I really appreciate that. So really, I think, to kind of wrap this stuff up, what this is about is really about quality of care in a community hospital, which really is about caring for our neighbors. That really is the bottom line, and what we really care about is caring for ourselves, our family, and our neighbors. Part of developing this is about having students engaged in this and developing new providers and new healthcare workers coming on. We have partnered with UAF's, the School of Nursing. AHEC is a group that we partner with that really helps provide a lot of education for new providers. And then we also provide internships and other levels of training through medical education here in Fairbanks. 11 of our TVC providers grew up here, and 4 providers married people who grew up here. So this literally is about bringing people from the community, getting them training and bringing them back. That's really important. And I think what that shows is that we're really committed to retaining and keeping the best of the best here in the community to take care of our community. I love this picture because this really, to me, epitomizes what a community hospital is all about. So here you've got Dr. Nace, who happens to be here in the audience tonight, Dr. Brunner, who are both from Fairbanks. So they're people from Fairbanks who are caring for a fellow Fairbanksan there in the picture. They both happen to be leaders in the FHP structure, very important leaders in the FHP structure. So it's about governance by local people. And you can also see right there, they're recruiting the next generation of providers. I can just hear Michelle saying, look, isn't this fun being a physician? We get to play with all these fun lights and these fun toys and all this great stuff. So it's really about recruiting our own and building our own is really a big part of that. So I think with that, Jim, you have a few words you'd like to finish up with?
Thank you. I think we are on. Thank you, Dr. Swenson. So, yeah, great concepts tonight. Thank you for coming out and sharing with us. I think this, for those of us from Fairbanks, there is a uniqueness to this community, and we want to try and exemplify that through our health system. This community vitality was somebody's phrase, which I really liked. And I come back to the commitment that Dr. Swenson referenced, the lifetime of excellent care. This is about commitment to the community, and I thought about this. One is kind of funny, as folks from Mayo, when you're CEO, all of a sudden there's a bunch of name dropping, and people make you sound very important. I'm just a kid who grew up in Fairbanks, who had great parents, great teachers, great mentors, and I'm proud to be here and be a part of what we're going to build in the future. Work with amazing people. It's not about me, it's about those 1,700 people that are out there with hands-on patients supporting operations. I look around, there are several in the room, I won't go around and name everybody, or we'll be here all evening. But it is great to be in a room like this in Fairbanks where I can see my 7th grade teacher. I can see the person who gave me my first job in healthcare. I can see 2 moms of friends of mine from college. I can see a girl I liked in high school. I can see this. This is Fairbanks. It's a wonderful place. And the phrase that was referenced about neighbors taking care of neighbors is truly who we are. I will tell you one quick story, and Dr. Swenson and many people in the room could probably tell similar ones, but as we've all aged, I'm very fortunate that many parts of my family still live here, both my parents, my wife's parents, I have a sister still living here. But just looking at our 2 sets of parents, and my wife and I, in the period from roughly last October through this March, we had some healthcare episodes, and you started to look back on that, and my numbers are, I think, correct here from my notes. We had 5 emergency room visits. I had to write this down. 5 surgeries, 2 procedures, 1 a colonoscopy, thank you, over a 120-day period. And that doesn't count the numerous doctor's office visits, et cetera. So that's just one very small family, and we can look around this room and then look around the community. So this neighbors caring for neighbors isn't just a slogan or an expression or a motto. This truly, it predates me, it predates many of us. This has been who we are since the beginning, and this is who we need to be going forward. Thank you very much for coming out again tonight. I'm committed, along with Dr. Swenson and the rest of the team, to continue to provide great care to this community for many, many decades to come. So thank you, and we're glad to stay for questions. Mr. Gray.
Yes. Mr. Lynch, and Dr. Swenson, 20 years ago or so, my wife and I had the opportunity, we decided to use our permanent fund dividends and go to your Scottsdale branch and just get complete physicals as a baseline. And after that, we've gone back and forth several times just for second opinions. Sometimes we'll take their opinion, sometimes we were very satisfied with the first opinion we had from the local physician. But the thing that impressed me a great deal down there was not at your clinic in Scottsdale, but at your hospital. I guess it's a teaching hospital also in Phoenix. And the first contact would be with a younger physician who was, maybe just fresh out of med school a year or 2 or so. And then we would have a consultation with his or her mentor, who was an older physician. And that was a very useful experience. I don't know how that relates to the e-consultations you have here, but I like that style of medical care. Mm-hmm. And I'm very happy to hear that you're going to be working with the local community. But how does that relationship work?
What you're really describing, I think, is a teaching hospital.
Yeah.
And that's kind of the place where all of us who went through medical school training, it was that model we learned from. And so we're given graduated levels of responsibility, and as we get more and more experienced, we work with mentors, we work with people who are above us in training, so starting out as medical students and interns and residents and fellows, and then get out into the, quote, real world. And that's a great opportunity. It's a great resource for us to learn, as well as a great resource for patients. I'm glad it was a good experience for you. Some folks have expressed frustration. It's like, I already told the story to 3 other doctors. Why do I have to tell it to you again? And so that's kind of a limitation, or one of the challenges that I think teaching hospitals face. We're trying to bring students here. We're trying to bring residents here. The pediatrics department at TVC has an alliance with University of Washington, so they bring up residents on a regular basis, and they work here. So if you were a child, you might be seeing a resident if you were to go into the clinic there. There are efforts afoot to try to build an internal medicine residency program in Alaska, and a few other things like that. But that really is, there's great value in that teaching ability, as well as having a second set of eyes, or third set of eyes, or fourth set of eyes that help see you. So
don't forget the geriatric department.
No, that's right.
Other questions tonight? Yes, Miss.
We have gone to the Mayo Clinic in Rochester twice. A wonderful experience. Place of art and beauty as well as medicine. And I'm impressed by the fact that you said you had 200 consultations
Yes.
within a year. Some of gotta pay for that, don't
Jim.
Yeah. Yes, I'll give my simple explanation, and the Mayo people might cringe while I try to explain it, but I actually think that the model they've developed is quite wise. Now, I come at things from the business end of healthcare, and I look at what they're doing, and Mayo looked at who they are. They want to expand their reach and their influence and their good work across the globe, really. And in today's world, they're smart enough to not try to do that through bricks and mortar and building and buying hospitals and clinics everywhere. And they're instead doing it through this network model and sharing their intellectual property. So we, in essence, are paying a fee to join into a network, a membership group, and for that fee, we have access to these services. So we are paying a fee for access to these services, but it's a good, mutually beneficial relationship. Is that an adequate explanation without all the technicalities?
A great way to describe it. I think, as Dr. Swenson said earlier, what was really critical about this when the patient receives an e-consultation. So Dr. Swenson said, I'm going to get another opinion from someone at Mayo. The patient doesn't pay out of pocket, and the providers in Fairbanks don't have to pay for that service. So they can, Dr. Strum and others can request that consultation, do what's best for the patient without any financial concerns. So the patient doesn't have to pay an additional fee for that interaction.
it? It seems to me that there might be times when Mayo, big as they are, might learn something from these new guys out in the network.
Oh, you couldn't be more accurate about that. And as Dr. Swenson alluded to before, we now have these events where we get groups together, and we call them collaboratives, and we learn from each other. And Mayo does not have all the answers, believe me. And in many aspects of healthcare, we continue to, it's a very bi-directional process where we meet with teams like the Fairbanks team. We take away from these meetings tomorrow a lot of information about how to do things better or how to do things differently. Or what is it like to be in a geographically challenged area? Patients come a long ways. Telestroke, for example, is a wonderful way to get expertise immediately. Tomorrow we're going to talk about something that Michelle and Laura Bruner might be interested in. It's called teleneonatology. So information where we can have our experts who sleep all night long in the hospital can interact with the care of a newborn baby that might be in a crisis situation. We'll be talking about that tomorrow. But we learn a lot from our interactions with the Fairbanks team tomorrow and from our other healthcare care network partners. So it's a very bi-directional process. Continued learning from each other is one of the greatest benefits of this relationship.
Thank you. In the back, yes.
Yeah, these consultations seem to be written reports to written reports. And is there any opportunity for real people to talk to each other? And how about the patient being involved in the consultation?
There certainly is, and I failed to mention a new program that's being rolled out from Mayo Clinic, and that is really for inpatient consultations. So with these e-consults, as they've been rolled out, they take some time. They take about a week to get results back. So I just submitted one today, for example, and I expect in about a week I'll get an answer back about this particular question I had. In an outpatient setting, that's fine. That usually isn't an emergency where we need to get an answer right away. But they're now rolling out an inpatient service where they can be telephone contacts directly from physician to physician in real time. And so if you have a patient who's an inpatient and they need to know some answers more quickly, that is now a service being provided. In terms of patients being involved with that, I don't know, is that something that you folks have talked about or have been part of the?
I could certainly make a comment on that. We use the term asynchronous consultations because the Fairbanks physician might submit the consultation at 7 p.m. at night, and our team member looks at it the next morning with all the information available. It's really difficult to line people up in different time zones to do this in real time. And also the biggest hurdle is licensure. So we have, all of our physicians can do an e-consult, an asynchronous e-consult, but we do not have licensure in the state of Alaska or in China or in the Philippines or in Singapore where we have other sites. So we can't legally do a face-to-face consultation with current guidelines. We can do this thing called an asynchronous review of information and offer suggestions for what might be best. So for example, if the patient was at our facility, in our office, what we would recommend. But currently, because of licensure issues and also the challenges of time zones, et cetera, we're not able to do face-to-face real-time consultations. Thanks for the question.
And I will look to Linda and Michelle to be the timekeepers.
Okay, the only thing I ask is that you repeat the question into the mic so that, because it's on tape.
Oh, thank you. So why don't we go here?
I have a comment and a question. My comment is that my go-to whenever I'm thinking about a new medical issue is the Mayo Clinic website. It's wonderful. My question, as I think about the Fairbanks, Greater Fairbanks Community Health Foundation, is there any transparency or information provided, financial information provided to the community about how our foundation works, our expenses, I think Mary Bishop referenced, how is this paid for?
Great question. So in part, yes, but maybe not on the level of detail that you're envisioning. There is the foundation historically, I'm hoping I'm going to quote this right because these are my bosses, so I have to, there is not a requirement to always publish an annual report, but they publish periodically, they publish a nice glossy annual report that has all of their finances in that. It's not an every year thing, it's an every few year thing. And so that information is available. It does not get into the details. It is at the sort of the macro level of the, the number of assets they hold, the revenue and the expenses and that type of thing. We do need to have more transparency in that as a community facility. There are no secrets, so to speak. There's a little bit of competitive proprietary concerns. There's certain information we'd love for other health systems not to directly have about us published out there for business purposes. But if you have specific questions, we can typically answer them if they're not publicly posted. I know that's a lousy, stumbling answer because it's not available out there today, and I can go back and inquire about what can be made available. Is that fair for tonight?
Yes.
Okay. And maybe afterwards I could get your name and I'd be happy to call you. Other questions? Yes, sir.
Is there any national organization of community hospitals? And related to that, if there isn't, do they do any lobbying at the national level about needs for GPs and improving that situation?
Yes. So the question was about, is there any statewide or national organization, association of community hospitals, and then what do they do to help lobby for help with the growth in the number of practitioners, et cetera? So yes, there's the big group is the American Hospital Association. And then within that are individual state chapters. So we have a very, very tight partnership with the Alaska State Hospital and Nursing Home Association. Mike Powers has snuck out, but he's been a driving force of that organization for a couple decades. So those are our core partners where we talk about policy issues, we talk about needs for the state, we talk about needs for our rural communities. We then have an amazing president of the Hospital Association. Her name is Becky Hultberg, former Commissioner of Administration under Parnell. She's an outstanding resource. She then interacts directly at the national level with the American Hospital Association. So we're actively engaged through that. They have a legislative issues list every year, and it contains those things such as physician licensure and many, many other issues. Does that answer your question, sir? Yeah. Other questions? Yes.
Pertaining to the
Hi.
person's height. How are you?
Great.
The personal health records are now computerized at the Tanana Clinic. And then when you end up, let's say, in the hospital, are you hooked up to the same records, or do they have separate records, or how does that?
Great question. Dr. Swenson, would you like to start this
Sure.
one off?
That's a great question. Right now we have separate EMRs, or electronic medical records they're called. They don't talk to each other very well. However, the practitioners can access them in both facilities. So for example, if I'm at the clinic, I can access the hospital medical records, so I can see when one of my patients is hospitalized, I can look up and see exactly what was done for them in the hospital, look at their labs, look at their x-ray findings, things like that. I can access that pretty easily. It's a little harder going the other way in that the hospitalists and the ER physicians at the hospital do have access to read-only to NextGen, which is the EMR at the clinic. So they could potentially get access to that, but it isn't quite as clean as we'd like it to be. What our long-term vision is really is to get us all on the same platform. And so if we're all part of the same organization, we should be on the same EMR. And I think probably in 2 or 3 or 4 years, we'll probably be there. But as you can imagine, transitioning from one EMR to another, and our Mayo friends just recently did that, how difficult and painful that process can be, and then learning how to operate in a new electronic medical record. It's like getting a whole different computer system and going from Mac to Windows and trying to figure out the differences what those things entail. So it's a real challenge. The intent of electronic medical records is it does give us the ability to share things more readily. And so, for example, I can send an e-consult from Tanner Valley Clinic to Mayo Clinic, and it's there within 24 hours or so with all the data that they need, and then it becomes part of their medical record, so that if you go down to Mayo Clinic, that's all already contained in their record there, which is great. That's the ideal we'd like to get to. But because of proprietary things and because there are competitors out there with different EMRs and because some are much better than others, it's a challenge to get to everyone being on the same platform. But that would be the ideal, is that we're all on the same platform, and as providers we can access patients' records, whether it's here, the hospital, Mayo Clinic, or anywhere else.
I have another question. It's just personal. The so-called Medicare annual health checkup for us older folks. Is there something better than that? Do we have to have those? Can't we just have where you address your personal issues rather than the federal concerns about your ability to stand up and sit down and the rest of the kids?
Could everybody hear that question? There is a specific definition for, in essence, an annual Medicare checkup.
Wellness exam.
A wellness exam. Thank you, Dr. Swenson. And so the question was about, can't we do it differently and focus on our needs and not on the list that somebody else has provided?
So yeah, a great question. I mean, what the Medicare wellness exam is designed to do is it's designed to give providers the opportunity to spend some time talking with patients about things that don't oftentimes get talked about. So things like end-of-life decision-making, things about their cognitive capacity, things like depression screening, healthcare maintenance things, so whether you need a colonoscopy or not, for example, and those things that patients oftentimes don't bring up, but they're still important in terms of healthcare maintenance. So it provides a way for us to get paid for providing that service. Now, you always have the ability as a patient coming in to determine what the agenda for that meeting is. And so if you're coming in for a meeting with your provider and you really want to talk about some issue or problem that you're having, that should supersede what's happening with the Medicare wellness exam. And that's something that you have the ability to ask for and say, well, I don't want to do the Medicare wellness exam today. Let's reschedule that for a different date, but I really want to talk about X today. So that's something that you can certainly do. But this is something that we're trying to promote and trying to use more often because it is a great service that Medicare actually provides for patients who are eligible for that, in that it does provide a way of paying for that service that oftentimes gets overlooked or pushed to the side because of immediate needs of other things. So I think it's a good service, although I'm sure it feels like you're being brought down a path that isn't really relevant, because there's lots of questions that we are required to ask, Medicare regulations, about, well, are you falling? Are you depressed? Are you, all these kinds of things that are really important screens, and we do pick up significant problems when we ask those questions. But I've had a lot of patients that say, well, no, I haven't fallen this year. Why do you care about that? So.
I want to go back to the question about the financial data. I had a chance to think about it. I don't know about the website issue. I'll have to ask or look, because I have not. I just don't know. I'm not aware. Where it is published every year is at the annual meeting of the foundation. And so I was thinking, in honor of Jeff Cook, who's not here this evening, hey, I would be shamed if I didn't promote the fact that any one of us can join the Greater Fairbanks Community Hospital Foundation and make a donation in doing so, providing you full access to our meetings and all that data. So half a joke, half serious. I'll follow up with you on the financial data. But the serious part is, with this community model, we all should consider being members of the foundation. I think it's only $25 a year membership dues to be a voting member. and a $1,000 donation grants you lifetime member status. So maybe that's a good place to end, and Jeff Cook can be proud of me for making my plug tonight. Again, I want to thank you all for coming. Thanks to Michelle and to Linda for, again, putting on this series, and we're proud to be here. Thank you, Dr. Swenson. Great presentation. Thank you to our Mayo colleagues. Linda, anything in closing?
I'm glad you asked me, because nobody's asked me that before, and this time I do have something.
Great.
Well, I'm not from Fairbanks, I've lived here about 20 years, and all of our lectures, sorry, all of our lectures this whole summer have been relative to our own personal health care, but there is a community health care, and I don't mean the hospital, I mean the community. And the reason I live here is because of the people, and we care about each other in a way that I've never seen anywhere else. And so to have this added and be the end of our summer of 2018, well, to tell you the truth, obviously tears come. So I'm so happy to hear what you've said and be a part of this community. So thank you very much.
You're welcome.